Hello, I'm Dr. H. Wesley Clark, Director of the Center for Substance Abuse Treatment within the Substance Abuse and Mental Health Services Administration, otherwise known as SAMHSA. SAMHSA's mission is to reduce the effect of substance abuse and mental illness on America's communities. To do that, we are committed to serving families affected by substance abuse and mental health problems. We know that individuals do not exist in isolation. Children are a part of families, and the behavior of adults affects the entire family. Substance use or mental health disorders suffered by family members need to be treated as family problems because they affect the entire family. An average of 8 million children are living with one or more parents with past year substance dependence or abuse. Even moderate alcohol use among fathers living with adolescents aged 12 to 17 may increase the risk of substance use among those children. Despite these problems, we know that children want to be with their parents, even when their parents are not functioning as the best role models. We also want to prevent the intergenerational cycle of substance use disorders. Parents who have struggled with addiction and are now living happy and healthy lives in long-term recovery are the best possible prevention role models for their own children. Breaking the cycle of addiction is essential to America's health and well-being. Childhood is short. There's limited time to make a difference. We are proud of what we've done to help communities respond to the needs of families in a timely manner. The creation of the National Center on Substance Abuse and Child Welfare has been instrumental in assisting communities to help families. It is important to SAMHSA that we partner with ACYF on this initiative. These types of collaborations serve as models for communities to improve the health and well-being of families.
I was like a broken person.
I didn't follow the requirements I was supposed to. I started them, but didn't complete them, and hid my kids from them for 2 weeks. And then the cops came to my house, and it was just horrible.
When they took my kids, that's when I knew. I didn't really think I had a problem, but I knew something was wrong. Terrible. You know, so. And you see it happen to other people, but you don't think it happened to you.
I think that for children who come to the attention of child welfare services across the country, a key factor is the substance abuse of their parents and caretakers. We don't have an exact figure, but we can estimate from the various studies that have been done over the years that approximately 1 to 2/3 of all families who come to our attention are affected by substance abuse disorders.
As shown by the parents we've heard from, families affected by substance use disorders and child abuse and neglect face many obstacles on their road to recovery. Typically, a family doesn't have just one challenge. They may have housing difficulties, domestic violence concerns, mental health needs, along with their substance use disorder. And each of these contributes to the issues that may have brought them to the attention of Child Protective Services. In the midst of this family crisis, they're faced with many challenges in navigating multiple systems, rules, regulations, terminology, and organizational culture. That process can be overwhelming and very difficult. Many jurisdictions have come to believe that navigating those systems takes a new approach with families. My name is Nancy Young. I'm the director of the National Center on Substance Abuse and Child Welfare, supported through the Substance Abuse and Mental Health Services Administration and the Administration on Children, Youth, and Families. This video provides examples of the strengths and challenges in developing a collaborative approach to improving outcomes for families. We're going to see programs that have been put together to exemplify policy and practice models that address collaborative barriers and have demonstrated improved outcome for parents and children. In Miami-Dade County's 11th Judicial District, they began a dependency drug court in March of 1999. They employ addiction specialists to assist parents connecting with substance abuse treatment. They also emphasize the critical importance of early childhood development through a partnership with the Linda Ray Center. The other site we're going to visit is Sacramento County's Department of Health and Human Services. They began in 1993 with several innovative responses to this growing number of child protective cases that involve substance abuse-related problems. They implemented comprehensive cross-training, institutionalized a dependency drug court, developed the role of early intervention specialists, and developed a relationship with recovery coaches who are an integral part of the dependency drug court.
We were failing our families. Before Dependency Drug Court, we only had 18% of families who actually reunified and had their children come home and their cases closed out with parents who no longer had substance abuse problems.
The families that present themselves have multiple problems. It's never just one problem. It's never just drugs, or it's never just mental health. It's never just homelessness, lack of education. And the children have a lot of problems as well. It's not about a clean urine. It's about changing the way you live your life, keeping your children safe, nurturing your children, giving your children a chance to live a productive, happy life without trauma. That's what the goal is.
Making our clients a priority, which is so important to have the whole community recognize that child welfare clients, parents and children are a priority is a big hurdle to overcome.
The importance of seeing the family unit as the client and not the child as one client and the parent as another client. And the importance of integrating the treatment into one holistic approach as opposed to having parallel treatments.
Yeah. So like here there's one for orthodontics, pediatrics.
It's so important to build integrity and trust, and it still is. But those first few years were critical. So we really watched everything, and it was important that we shared our information and that we were all upfront with what we were doing. Everyone was involved with building our policies and procedures.
The most important thing to make a system like this work is collaboration. Having everybody at the table from the very start, not bringing in a system and trying to impose it on some of the parties in the system that may not have buy-in. You've got to get buy-in if it's going to work.
At the National Center on Substance Abuse and Child Welfare, we've developed a framework for looking at the connections that need to happen between systems for families. We refer to this as the 10-element framework. It came about by the recognition that communities were often facing similar barriers and creating very similar solutions to those barriers. We took those barriers and solutions and organized them in a way that provides guidance to states, to tribes, and communities in the work of their collaborative efforts. When we say, go work with those other systems and create those partnerships, the framework provides a blueprint of how to do that and how to assess the effectiveness of those efforts. These key linkages are the bridges that are needed between the separate systems, and we've created some policy tools to facilitate building those bridges and ways to monitor their implementation. The elements are organized in 4 broad categories: mission and values, practice, the organizational changes needed to support the practice change, and monitoring the outcomes achieved. The framework allows a site to measure their progress using a tool called the Collaborative Capacity Instrument. It measures how they're doing in each of these areas of system linkages. We're going to talk about each of these elements and how the 2 sites that are being spotlighted in this video implemented changes in their systems in these areas. The first of these linkages that have to be built is an understanding of the underlying values, belief systems, and practices that drive each family-serving system. That understanding provides a mechanism to create the collaborative's mission and to detail the principles of working across the systems. The core principles of working together and the outcomes to be achieved provide the glue to keep the collaborative together and keeping the families as the focal point.
Everyone agrees that we want parents to be safe, nurturing parents. Everyone agrees that good quality treatment on demand is important, and everybody agrees accountability is needed for people to succeed. And so everyone came together and said, those 5 or 6 things we agree with, after all the yelling and talking and fighting.
All the partners in the systems have the same goal, which is to provide children a safe and nurturing environment where they can grow. We do that by working with the courts, by working with community partners, by working with other service providers, and trying to access all the services that the parents will need so that we can provide them with the tools that they will need to assess that goal.
You have to listen, you have to understand that there's expertise in different areas, that there's turf interests, and you have to work with that in a collaborative way, and really make people understand, or allow people to understand that they're part of this process, that you need them and they need you.
Most jurisdictions we've worked with have recognized that their early efforts need to focus on their screening and assessment procedures and how to link families with multiple providers. One of the resources that the National Center has developed is a monograph called Screening and Assessment for Family Engagement, Retention, and Recovery. We refer to it as SAFER. In developing SAFER, we recognize that each of the systems has a way in which they are conducting screening and assessment and have practices in place to engage families in care right now. So, understanding the system's screening and assessment methods, the task becomes clarifying what needs to be communicated between the systems. We often say, who needs to know what and when, as a way to clearly operationalize the communication that has to take place between the systems.
Early intervention specialists review all of the detention reports or non-detaining petition reports so that we can see if there's any possible alcohol or drug issues. Dealing with resistance is the biggest part of our job. We just try to help them get past the resistance to CPS, resistance to services, denial of having a promise, to just get them to open the door to maybe this can help me out.
So I said, okay, I'm going to do it, and I went and signed up for it and had my interview with James at STARS. He's a really nice person.
So once a family member gets to a treatment program, each of the collaborative agencies has the opportunity to encourage the parent to stay in the recovery process and meet the requirements of Children's Services, the court, and the treatment agencies. Of course, there are many obstacles that confront parents who want to keep their families together while they deal with substance abuse. Judges can respond in a way that supports continued engagement and recovery. The parent's attorney plays a critical role in ensuring that family members take quick action and stay in the treatment process. Many jurisdictions, Miami and Sacramento included, have figured out a way to put recovery mentors or recovery coaches, some program in place that engages families and keeps them retained in that change process. Working together on retention strategies among all of the stakeholders makes a huge difference in the families' lives.
Accept the notion of services on demand. What that means is if a client comes to court and they're using substances, that they don't have to wait to get into treatment. They can get into treatment that day. If that happens, the rate of success increases. They will go to court, go to the initial hearing, then they'll go right into treatment. They don't have time to go home and use. They don't have time to go home and go to their people, places, and things where they're going to use anyhow.
I didn't want to deal with why everything was going on. I used drugs to feel loss. Me and my friends used to just say we're just blowing in the wind.
A relapse doesn't mean you're out and we're done with you. It means you've had a relapse. Now let's keep going. We've had families where a parent has been close to graduating dependency drug court and has had a slip up. And the true test of that particular parent is, okay, I made a mistake, I'm done, I'm going to walk away. Or, okay, I made a mistake, I'm going to re-engage immediately and actively do what I've been taught to do, utilize it not only for myself, because that's the most important thing. The recovery must be for the individual, first and foremost.
When clients then take into the STARS program, they are assigned a recovery specialist. A recovery specialist is always of the same gender. In motivational interviewing, we're not telling our clients what to do, we're asking our clients what their goals are. When they're being shamed, they are inclined to run away and hide. But when they are made to feel safe and supported, they'll be more inclined to communicate, to come to us, and to be honest with us. And that's a key component of recovery.
So we do all of our drug testing completely on the spot. We hardly ever send anybody out to the lab to test, and the reason why is the waiting period for the lab is about 2 weeks long before you actually would get a positive result back, and a lot of things could happen in a 2-week period of time.
However, if there's a positive drug screen, we also try to use that as a therapeutic intervention, and we try to encourage honesty, try to get them to see what happened, what was the relapse all about. We don't use it as a punishment. We don't necessarily just close the case, throw everything out.
When I first got into this program, I was very resentful. I was mad. I was getting ready to go to the Capitol and do a fast to get my son back, you know. I really didn't like this process at all. And as I went through the STARS program and realized that these people that are trying to teach me about my disease have gone through it themselves. So that was kind of it was a blessing, because it wasn't somebody who's never experienced what I've experienced telling me what I need to learn, you know. I mean, it was somebody who had actually been there and was doing the deal, staying sober one day at a time.
So much as just want you to be as honest as you can be.
She didn't make me feel like I was a bad parent or anything like that, because that was the most devastating things that has happened to me yet, is feeling that you failed your children. You know, I was just broken at the time, and she got me engaged and just guided me through, you know, what needed to be done. She was always clear about what needed to be done, what was expected of me, and the consequences if I didn't comply. And so that's what I did.
The last few decades of research about children of substance abusers shows that parental substance abuse can have a tremendous impact on children. And most estimates are that the majority of children in the child welfare system are children of substance abusers. Particularly for young children, they really need continuing skilled support and continuity in their relationships. For all age groups who may have been prenatally exposed to substances, recognition that potential neurodevelopmental effects is critical. And without effective intervention, children are at risk of developmental delays, and it's clear that children of substance abusers are at higher risk of developing their own substance use disorder. The special needs of both prenatal exposure and living with active substance abuse must be addressed in prevention and intervention programs.
Everything about a young child's life in the first 3 years is about how they exist within their primary relationships. So the developmental assessments we do on the children when they come into the Linda Bray program are one part, but we actually do relationship assessments. We use videotapes and we do behavioral observations to see how does the parent and the child interact.
We do an intensive clinical assessment, which is called the parent-child assessment, and that is something that we do turn into the court. We screen and assess all different needs that the parent or the child or the family in total may have, and that is included in that report, and we make those recommendations for the court. And in addition, we also speak directly to the caseworkers that are involved with the families, so that if there isn't a court hearing that's coming up right away, we make sure that we get in contact with the caseworker so that they can already start those referrals so that the families can get their needs met as soon as possible. Oh, yeah!
We started the parent-child psychotherapy to work on the attachment and the anger issues that her son had with her. The second thing I did was immediately make a recommendation that Audra be allowed to move to a facility where she would be allowed to have her children with her in a supervised setting, and have her children come here to the early intervention program to work on any developmental delays that existed with her son.
Many of our parents do not have custody of their children and are at risk of losing custody permanently. These children oftentimes are in the custody of the Department of Children and Families. Through the years, we have been able to work out with the department that when a child is brought here, that the Department of Children and Families will allow us to share custody with them.
As we've already talked about, families don't come with just one challenge. That means that the systems can't be unilateral in their approach. Bringing community and family supports and recognition of the critical role that the recovering community can play are necessary ingredients to make this work and to support families over the long run. Engaging in support groups, community organizations, and the faith community can all be huge factors.
The overlying philosophy is guided by a model which is called the Comprehensive Continuous Integrated System of Care. So families who have mental health and substance abuse issues, and how to integrate those problems into a holistic treatment approach.
If I had started with these
As we
numbers
move
over
along
here,
the process, we look at GED, education, and vocational. Another aspect of our collaborative are the people that deal with vocational and housing. Housing, of course, is always an issue, but they're all part of our collaborative.
I think when I realized they were really there for me is when I talked to him about, I got a sponsor and I was doing some other stuff on my own as well. And he was like, right on, that's what I like to see. And he told me, you know, a support group doesn't just have to be A or NA. It could be going to church, it could be a Bible study or a book study or, you know, something that's benefiting you as a person, you know?
Of course, none of this collaboration works unless there are effective and efficient ways to share information across the systems. Not only the type of information, but in a way in which data is collected that makes sense to policymakers and eases the burden on the line level worker.
The STARS program collects data and shares with child welfare, CPS, dependency drug court, and treatment providers. We generate a twice-monthly report which consists of treatment attendance, testing results, number of contacts that clients are required to meet with their recovery specialists, and how many meetings, support group meetings they've attended that they were required to attend.
Each of the agencies and providers support each other. We openly share information about the families. We have constant communication with each other. This allows us then to all have the same perspective of the family, to ensure that we are all headed in the same direction and have the same goals and objectives for the family, and prevents us from having mixed or confusing communications to the family.
Part of the drug court protocol calls for very intense communication and staffing. So once a week, we all get together and we staff the cases. What that means is that we all sit down like in a round table and we talk about their cases.
Everybody knows what's going on in your case. You know, and so that's what creates the safety net, because everyone is on the same page, which creates a sense of security.
Every collaboration has to learn how to speak each other's language. You can't have effective communication, effective screening processes, or any of the other system linkages that are necessary unless you understand the basics of substance use disorders, how child welfare works, and how the court system works. The National Center has developed several tools to help with this basic education. We offer online training, monographs, and training toolkits for frontline workers. There are many resources available now in this effort to provide that training. We talk about workers being trilingual. They can speak substance abuse treatment, they can speak child welfare, and they can speak the court system. That only helps families when they're getting the message in a common language.
Warning signs of possible slip or relapse. So what is a relapse?
It's really important with the
relapse.
Alcohol and Drug Training Initiative that we all work together
that we are cross-trained, that we understand what the courts have to work with, that we understand what the CPS has to deal with, that we understand what alcohol and drug goes through, because it's important that we can actually get a thread and work a client through that thread as opposed to having them all get siloed treatment. When they get siloed treatment, what happens is that clients fall through the cracks.
We train our lawyers to make sure that your client is open when they discuss what the relevant issues are, especially when it comes to substance abuse.
He didn't do it because there's any hammer over his head. It's because he put some thought into it and he said, this is what would serve me best in my life. Lessons learned from AODTI, I think one of the biggest ones was getting the buy-in of mid-level management. We sort of had to back up and come back in and do supervisors trainings saying this is what we're doing, this is what your staff is getting. And it was a key piece that we didn't get when we had first started this. And so anybody coming in deciding to do this, I highly recommend. If you don't have the buy-in of middle management, it's not going to fly. It's not going to be able to sustain itself in the workplace. I mean, you can have them go to training, and that's great. But if you want change, you have to have the buy-in.
So some of you watching this might be already saying to yourself, how did they pay for all those services? It can be complicated, and the reality is that the program staff that are able to put together these systems may not be the same people putting together the budget. It's very important that the people allocating budgets understand the reasons for creating and sustaining a collaborative approach to working with families.
Funding for the Dependency Drug Court and our STARS program took creativity, and it took vision, and it took champions, and it took risk. We had a program manager and a presiding judge who wanted to make this work.
The problem with a lot of this work is that it all started out with grants, but finally the Department of Children and Families realizes that this is really effective, and they're paying for a lot of this dialectic therapy as well. So it's now become not so much soft money, but it's part of what we do. It's a valued component.
We would see some changes, and I'm open to explore that, but
Collaboratives require glue. Without it, when there are bumps along the road, the group can take a wrong turn or they get derailed. Outcomes are that glue. It means that the collaborative has reached agreement on their desired results. Understanding that each of the systems plays a role in getting to those results keeps everyone at the table and provides a way that community stakeholders can invest and reinvest in programs that work. Collaboratives without clearly defined outcome measures may be sharing information, but they have little hope of being sustained over time.
Some of the outcomes that we've had in drug court is really higher success rates and reunification. We've minimized the revolving door system where the clients are coming back into the court on new abuse and neglect.
The evaluation strategy for Sacramento County started with we didn't want to do anything more than what we were already doing. In other words, in order to ask people to take on an entire new program and change the way they were doing things, we didn't feel that we could also ask them to learn a new database and new forms and new everything else. What we needed was buy-in. So part of our strategy was that we were going to use our existing data systems, and that was a big piece. That didn't mean we weren't going to add additional elements or unique identifiers so that we could match our information in our databases, but it did mean we were not starting from scratch. Child welfare offers reunification services up to 18 months. So when we first started this program, year one, comparison group was 18%. Year one at 18 months was 24%. By year 5, we're almost at 57%. These are children who are returning to the care of their parents. They're returning earlier. The county saves money. Our
children are healthier, for parents are healthier. So all the way around, that's our main key outcome, is increased reunification rates. And for those that unfortunately cannot reunify, we also have the majority of those cases going on to the permanent plan of adoption, which is the next best permanent plan.
Interestingly enough, I looked at my first class. We had a drug court graduation here, a statewide graduation, and one of our first graduates spoke. So I went back and looked at the list from the first graduating class. There were 12 women. None of them have been back in the system. And they keep in touch with us. They are working at drug rehabs. They are property managers. They are x-ray technicians. They are involved in our women's group. Mom is graduating today, right? Laversia is graduating. I'd like some of the other drug court parents that are just starting, I'd like them sitting in here so they can listen to her.
That courtroom gets quiet and you can see the effect it's having on all the people around them. When a client stands up there and they say, "I got my child back," and you can see the people in the room that say, "I want to be just like them. I want my child back too." You know, you can see it.
You actually have to go to court and you have to do all the programs, all the parenting, because it really does teach you a lot when you go through therapy and parenting and everything, you know, so it's worth it. I mean, as long as you get your child back at the end, it's all very worth it.
Most I can say is that it's tough and it's hard sometimes, you know, mentally, but it benefits everyone in your family. It benefits yourself and your children, and staying clean and sober, and it's all worth it. Being here and in dependency court working, all of us together, it has tremendously turned around our lives, and I am so thankful. And without any of this, drug court, the village, it would have been possible and he would have been somewhere else.
I remember when I graduated and she came down off of the bench to come down and take a picture with me. It was like a great moment. A judge is actually coming off the bench to congratulate me on being successful. 6 months prior, the judge had told me that I couldn't take care of my own child, and now they're telling me, congratulations, you've made it, you're a better person.
After receiving treatment, I can see the joy in their face, not only the mothers, but also the children.
We invite you to visit the National Center website and to be in touch with us on any of these topics and ways in which we might be of assistance in your community. We recognize that collaboration takes time and effort, but we also believe that we have no time to waste. Just as children go through developmental phases, collaboratives go through phases of maturation. As we hope you've seen in this video, the good news is that over the past decade, thousands of hardworking professionals and community members have laid a foundation on which new and stronger structures of collaboration can be built. We have the models, the tools, and the frameworks we need to connect services to help children and families. The next step is yours to take. Familiarizing yourself with these tools and models is much less difficult than it once was, because of the innovative work done by many of your colleagues around the country. Online training is available, and so is our website, where you can find the materials developed by the many national and local groups. We can make the lives of these children and families better by making better connections among our agencies and services. Please join us and take the next steps toward that better life for hundreds of thousands of children and their families.